Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
It is my great pleasure today to introduce Dr. Tom Graber, really a lifelong friend of mine, at least professionally anyway. Tom, thank you very much for coming to Ann Arbor today.
My pleasure to be here, and I would say we're lifelong friends personally as well as professionally.
That's true, with your son being my daughter's godfather, I guess that...
A student of yours,
right,
and an associate in practice, so we've had a long familial relationship.
Right. Well, it's a very great pleasure for me to have Tom here today. We're going to talk about chin cup therapy, but tonight will be the formal announcement of Tom Graber being the first person in the history of the University of Michigan's 175 years, plus 175 years, of receiving an honorary degree, which will be granted in December. And so I congratulate you, and I think this is going to be, should be a very fun day for you, and also in December it certainly should be a very good time. So congratulations.
Thank you. I'm mindful of the honor. I appreciate it, and I'm happy to do whatever I can to try to live up to the award.
Well, you already have done that. That's not a problem. We have talked, you and I have talked about for many, many years about orthopedics, and certainly perhaps you more than anyone got me interested in the wide variety of orthopedic appliances. And the one thing that certainly you have had a great influence on the profession is the use of chin cups. Over the years, we've seen the Frankel appliance, the FR3, the orthopedic facial mask, and the chin cup perhaps being three of the most commonly used types of appliances for class 3 malocclusion. Can you give us a little bit of history on how the chin cup came about and how you personally got involved in this kind of treatment?
Actually, I was fortunate enough in practice to practice with Fred Noyes. He was 80 when I went in there as getting out of graduate school at 30, and he was telling me many times of what Edward H. Angle did and what his predecessors did. And one of the things he required was that we read history. And so very early we found out that people with the so-called Habsburg jaw, the lantern jaw sticking out in the middle of the room, they were trying to control this. And actually as early as 1850 or 1860, there were crude devices where they had head caps. And in Angle's 7th edition, you have this classic picture of a net head cap fits over the head with the elastics coming down and a chin cap. So the idea of using a chin cap certainly is not new. For me, my initiation, of course, after the historical part was I did my doctorate in cleft lip and palate, and they had these cases of mismatch of maxilla and mandible. Actually, most of them were maxillary deficiencies, but we had this strong mandibular prognathism, or pseudoprognathism in most of these most of these cleft cases, and we had to find some way to adjust the mandible to the retruded maxilla. And so we were desperately looking for orthopedic force, of course, and for a combination of dental and orthopedic response to correct the sagittal malrelationship, the protrusion of the mandible and the relative retrusion of the maxilla. And so we turned originally to chin caps, and I was very active in clinically treating these cleft palate cases. At one time during my PhD, from 47 to 50, over 50% of my cases were cleft palate. And it was a very disappointing thing to see us put braces on, and Noyes would have them on for years, and pulling the upper incisors forward and the lower incisors back, and we never finished our cases. And so I was disappointed with that, and I wanted to find something a little bit more than a dental answer to the problem of the skeletal malrelationship that we had.
Was anyone teaching chin cup therapy at that time?
You know, actually not. It was passé. It was Angle's 7th edition. They weren't using it at Illinois, the font of higher Angle learning, where everything was, where they worshipped Angle. That was one thing they didn't pick up. So actually the chin cap was not being taught.
So how did you come about using this kind of appliance?
Well, I just felt that we had to do something beyond putting on braces on teeth to straighten teeth to get rid of the sagittal malrelationship. And I thought that some of the early work, that it would work. I was in the hospital there. I was with the orthopedic department. I watched them guide long bones, the growth of crooked arms. I watched them putting on splints, putting on force, and straightening spines, straightening long bones. And I thought, well, if it works for endochondral bone, certainly membranous bone is more responsive, and it should work for membranous bone. And that was the rationale for it.
Now, how long, you've obviously used chin cups then for 30 or 40 or however many years, a long time anyway. What kind of cases now, if you were to look at a sample of class 3 individuals, what types of patients would be most or would benefit most from this kind of treatment?
Well, we learned by many mistakes, of course, and we were overly optimistic about the results, and some of our results were partial. Later on, there was some retrogression, so it's not a be-all and end-all, and we learned that there are strict limitations on what chin caps can do and can't do. We learn more about diagnosis and not just treating everything as a mandibular prognathism, but the cases now that respond best are the ones where there isn't a really severe familial hereditary pattern case where you have fighting against a hereditary pattern. We have a mild problem, a mild to moderate problem. There are cases where you have early anterior crossbite, where the mandible is lower incisors are forward, and you have the condyle being brought forward out of the fossa, the mandible actually restricting the maxilla as it wants to drop back, and you have an activator effect like a Frankel FR3 or an activator treating a class 3. And so you must get in. What do you need to do? You need to get in early at 8. I've done this on 18 months of age, 2 years of age, and we have one family, he's a dentist in our building in Kenilworth. He had 9 children. The mother was a class 3, and every single one wore a chin cap.
Really?
Only 2 of them wore appliances, and every one of it worked. So we started at 18 months to 2 years. This is Dick Lammermeyer and all his kids. And so they were wonderful patients because he was a Prussian perfectionist, and he saw that those kids wore those chin caps. And so there's no question that getting in early and doing what you have to do, you can improve the sagittal malrelationship.
If you were going to start, let's say on a mixed dentition patient, someone, well, maybe even late deciduous dentition, what kind of protocol would you tell the patient and the parent to follow?
Well, first of all, mixed dentition, late mixed dentition, unless they're mild problems, is probably very limited in what it's going to do. And remember now, we're just talking about chin cap only and
Right.
nothing against the maxilla. There probably isn't that we didn't do it. We did do it in those cases, and in our cleft cases, and otherwise, in other cases too. Well, we would tell them they'd have to wear a chin cap 12 to 14 hours a day and at night, largely in around the house. And we didn't have them wear them to school. Probably if we had done that, we'd have had obviously more controlling effect on the mandible. But as it was, why we would get certain untoward effects, like some soreness on the chin, particularly in redheads and blondes who are more susceptible to the chin cap and the perspiration and whatnot. So we'd have them wear it if it was a mild problem, 12, 14, if we get 16 hours a day. And we'd check them, every 6 to 8 weeks.
What would you say the ideal time to see, if you have, let's say, sort of a garden variety class 3, I'm not talking someone who's very severe, what would you say, if you had a general dentist say to you, when would you like to see these patients? When would you like to see them?
I want to see these kids at 2.5 years of age, and no later. Those are our greatest successes. In the same way, and I can show this whole family, there's no question. I learned by making mistakes and the experience of treating early that growth guidance literally must guide growth and prevent the deleterious effects of adverse reaction by having an activator effect on the mandible. Because what happens in these cases, as the mandible is brought forward, it isn't that you enhance the growth that much, but you change the direction of growth. And the condyle grows upward and backward. As Lyle Johnson says, you unload the condyle, and then the condyle tends to grow backward into the fossa, as it does with activator cases. And when you do that, it perpetuates the mandible in a forward position. and particularly in crossbite cases, unilateral cases, as Egermark, Erickson, and Thielander have shown, there's no question that you get an activator effect from class 3, unilateral, and bilateral. You know the study, 3 to 21 years of age, that they did, and it showed, no question about it, an enhancement of the prognotism. So I think you'd want to get in early. And a long answer, but I think the earlier the better, the more. And you may have to go, and that doesn't mean you're done then. We had to go back on in many of these cases again in the mixed dentition. So in answer to that, that's a second assault on the problem. And finally, in the permanent dentition, and we would also in mixed dentition use palatal expansion in these cases, by the way. We would not only use a chin cap, we would use an upper removable appliance with a jack screw in the center, and we would expand the upper arch, because in many of these cases, the maxillary, as we found out, the maxilla was deficient in width, and we would use a palatal expansion appliance in conjunction with a chin cap. So the chin cap by itself is only one approach to it. We needed other appliances.
Now, in the early 70s, Jean Dallaire from France popularized and further developed the face mask, the orthopedic face mask, and Henri Petit has come on since then. How does that fit into your concept of class 3 treatment?
Well, by that time I had learned that all class 3s are not mandibular progs, that there were many of these for maxillary, and particularly in the cleft cases, maxillary deficiency, the sagittal malrelationship or retrusion of the maxilla. So it fit in beautifully when we saw this, because we had already realized this prior to this. We would use chin caps, and we would put horns. There were little metal horns sticking off the chin cap, and then we'd have rubber bands from that going to the maxillary arch. But it was crude, it was not very efficient, and so the Dallaire mask provided us with an effective means of maxillary protraction using the forehead and the chin as an anchorage, as a reciprocal anchorage, but also having some retrusive effect on the mandible. And what it does, again, I should point out, when you put pressure on the chin, and Don Woodside pointed this out a long time ago, you tend to auto-rotate the mandible downward and backward. As you do, you move the mandible to a little bit more of a retrusive position sagittally. You get eruption of the posterior teeth, and this is good too, because in many of these class 3s you have a maxillary vertical deficiency as well as the sagittal. It's a three-dimensional thing and a transverse deficiency. So what the chin cap will often do, and the Dallaire mask does, rotates the mandible down a bit, posterior eruption, and brings the maxilla forward. So it's a combination of a three-dimensional assault. That together with the, now I know in your case you use rapid palatal expansion. You follow the same philosophy, only we did it with slow palatal expansion and with gradually turning the appliance, the maxillary removable with the jack screw and the usual key.
Mm-hmm. Now, one of the concerns that many practitioners, especially people who have not had any experience with the chin cap, is the issue of TMJ problems. And certainly, if you've been doing this since the 1940s, you have a very long history of experience in TMD. And certainly with your current expertise as an expert witness in litigation cases involving temporomandibular disorders, you obviously have an opinion about the efficacy of chin cup in this regard.
I was with Jack Thompson in practice and in school for 5 years. Jack Thompson probably alerted us more than anyone as orthodontist to TMJ problems. Jack Thompson would not even use a guide plane on incisors because he felt that might create a TMJ problem. And he was totally, unalterably opposed to chin caps. He said this would create TMJ problems. In fact, I would say the percentage of cases, a fraction of 1%. We just never ran into the problem. Logically, you would think so. You would think that if you can functionally retrude the mandible with occlusion, with nocturnal parafunctional activity, that a chin cap might emulate that. But in actuality, with chin caps, almost never. Occasionally, we'd have some sore joints. These kids would overwear them if they wore it with, say, 3 rubber bands, where they would put 6 or 7 on. And in those cases, why I think it would just tell them to stop wearing it, but we did. To my knowledge, I cannot remember a single case where we created anything more than a temporary problem with clicking, I can't even recall crepitus, and some neuromuscular soreness, which goes on anyway with conventional therapy. So it just doesn't happen, and I am very much aware of what we can do orthodontically to create TMJ problems. It isn't a simple matter that orthodontics doesn't create. We can. I think that the evidence is that we as orthodontists must be careful because there are certain types of patients, certain types of problems where we can do it, but with class 3s, why, I must say, with the chin cap and with the Delaire mask, it was not a clinical concern.
How much force would you use in a typical chin cap case?
We would use somewhere between 15 and 24 ounces with the chin cap. 2 to 3 elastics on the side, and I don't remember the exact measurement of the elastic, between 15 and that got me into maxillary orthopedics. That's how I got into it, because as you know, or this is history and you may want to know this, the ADA just voted down in New Orleans this past 5 days ago to change the name of our specialty from orthodontics officially to dental facial orthopedics. We introduced the term, we introduced the concept for what it's worth at that time, and our journal has been Journal of Orthodontics, Dental Facial Orthopedics. Now we are the specialty of orthodontics and dental facial orthopedics, and I think it depends largely on much of the work we did with the chin cap, the orthopedic effect of growth guidance, and on the use of orthopedic force against the maxilla in class 2. So growth guidance is a fact.
Well, you've had an uncanny ability over the years to identify new technologies that would be useful, and certainly the area of dental facial orthopedics is one of them, that starting with the chin cap and then going into various types of class 2 mechanics. I think probably you more than anyone has been responsible. I do know for a fact that you were responsible for the resolution to change the name of the specialty to orthodontics and dental facial orthopedics. That's correct, isn't it?
That's correct, and we met a lot of opposition too. There were a number of people who thought it was wrong that orthodontics, ortho, straight, don's tooth, describe what we do. Everybody understood that, but those in other phases of dentistry who were not non-specialists in orthodontics adopted the so-called orthopedic concepts without the diagnostic acumen that we have and we need, and it was imperative that if there was going to be any growth guidance, we were the ones to do it because we know how to do this. I think one fact here that I haven't emphasized, all these cases require very careful diagnosis. You ask what protocol. The protocol appliance, but the first thing is a very careful, thorough analysis of the problem, and that means sagittal, means lateral head films, a good cephalometric analysis measuring the anteroposterior, the vertical, and an anteroposterior film, the transverse dimensions, the problems that we face, so we know where our problems are. And so unless you have that adequate diagnosis and understanding and knowing growth and development as orthodontists do better than anyone else, then I don't think you should talk about orthopedic force or growth guidance. The mistakes we made in the beginning and that other people make too often are not correlating our knowledge of growth and development and growth guidance.
What kind of clinical problems, aside from the redness issue, what other kinds of clinical problems did you run into or have you seen people run into in the past using a chin cup type appliance?
The most common one is partial correction, where we didn't get enough and we never knew. An unfortunate thing, we were relying on patient compliance, and you don't really know with a head cap, even with the modern measuring devices that they have, which tell you how much they wear them. These still could be, patients get around. We never knew how much the patients were actually wearing the appliance. Was this lack of patient wear? Was it lack of tissue response? But this is partial correction. And there were many of those cases, certainly in the cleft palate cases, it'd be so great in the beginning, I'd get a certain amount of it, maybe some of it was condylar retropositioning in the fossa, but we would certainly see a certain amount of change, and then it would tend to slow down. The second thing, what have we run into? We've run into a rebirth of the class 3 type pattern, a tendency to return. So in the later we treated the cases, the less successful they were in the long run. So it's fine, we'll correct it early, we get some anterior compensation of the teeth, some widening with a removable appliance. When we got into the mixed dentition, particularly in boys, in the later growing boys, we would have a dominance of the morphogenetic pattern, and if it's class 3, they would tend to return to that. Now, you asked about TMJ. Some of those cases later, in the end, and I have now the daughter 19 of one of our, she's her mother's class 3, she was class 3, we went through this whole routine, and now she's getting some tendency at times of clicking because she has a very, very tight anterior overbite, and she's a stressful young lady. She clenches at night, and so I think it's not just the anterior relationship, but I think it's also the stress, strain, tension, release problem she has. But there's no question that partial success, the later you treat, is a concern.
Have you ever used these kind of appliances in adults?
I tried it, and what I did, and I got some success. I'll tell you what we did. I think of one man particularly was a priest with a terrible prognosticism. He did, and of course, now we always mention surgery. Earlier we didn't, that if this doesn't work, it would be a surgical case, and this is obviously a given. But he didn't want to do this, and so what we did, we gave him a chin cap with a downward pull on the chin, and then we gave him vertical elastics between the upper and lower arch to erupt the posterior teeth, and then we used class 3 elastics. What we were trying to do there is get an auto-rotation of the mandible downward and then get eruption. It helps to do that at night, and then with the elastics, why you're able to, and with an anterior bite plate inside to prevent the posterior teeth from being in occlusion. You understand what I'm saying? Because they won't do much good unless you have something to keep them from coming together at night. We have used it with some success for partial success there. In this case, actually worked out pretty well, but we ended up with the lower incisors tipped back at about 80, 79, upper incisors out at about 115, 120, I don't remember, but it was a dental compensation and a jaw position compensation. There was no orthopedic growth guidance. It was to help in the dental correction.
Let's assume again you have a garden variety type class 3, nothing too severe. What is the oldest age that you could get in with some type of chin cup treatment and be reasonably assured of success? Let's say also given the fact that there's not a major history of class 3.
6 to 8, 9 years of age. I wouldn't want to go any later than that. If it's a girl who they mature more earlier, of course, as we know. So I think you really want to go toward the younger age. I think patients, one of the things there, patient compliance is also better in these earlier ages. I'm very much impressed with mixed dentition or deciduous dentition. Anything beyond that, our successes have been partial and temporary in most instances. We can all show cases where we succeeded, but if it's any real magnitude, I think you have to either treat them early and know the pattern and know the hereditary pattern, and you have to have a compliant patient, and you have to think in terms also, not just a chin cap, but of the protraction appliance, the maxillary protraction, which is so often necessary in these cases. And no longer do we think only in terms of retruding the mandible. And I think it's important to mention, I think you want to hear this, I don't think that we really, despite the work of Petrovic, beautiful work showing how he retarded the prechondroblastic glare of the rat with pressure of the chin cap and showing the reduction in the thickness of the prechondroblastic glare in the condyle. I think this does not transmit, it does not become clinically a major factor. I don't think we do a lot of growth retardation. What we do, and I'm convinced I can show this with radiographs, is that we change the direction of growth of the condyle, such as it is, from upward and backward to upward and forward. And that allows the body of the mandible to drop back a little bit. And I think that's our greatest effect. I do believe we're able, over a long period of time, to actually reduce the prominence of a symphysis by flattening, and I've done that and shown that. That at least helps in the profile, helps in the facial cosmetics, but in other words, there is local bone growth guidance. And you know, they showed this many years ago. Historically, if you look at the Aztec Indians, Peruvian Indians, and you watch what they've done with membranous bones with binding the head and binding the chin, there's no question that we can change the direction of growth. Whether the amount can be changed that much, I don't know.
Are there any other comments that you'd have that you think would be helpful for someone viewing this tape as far as they're getting into class 3 treatment? What are some of the things that you've learned sort of in the big picture as far as class 3 is concerned?
Again, repeating. See them early. If they go into the hands of somebody else who doesn't recognize the need for early treatment, it's going to be too late. You have to recognize that all class 3s are not just one-dimensional, they're three-dimensional, so you must assess the anteroposterior, the transverse, and the vertical problems, And I think that if you recognize that it's not a chin cap alone or face mask alone, you need to get in with other auxiliary appliances, and you have to tell these people that in many instances they're going to have to think in terms of full appliances. And finally, you must say, you know, we'll do our best. We don't want you to go through surgery, but the most successful surgery through the years, starting with Blair in 1895, has been the Dingman type operation, which Dingman copied VP Blair in St. Louis. That's been the most successful in class 3. So the surgery isn't the worst thing in the world, unlike some of the Lefort 1 cases. So surgery may be a problem. So I think this is the long-term thing, is what we tell them. The earlier we get in, hopefully, the better we can prevent the need for surgery. But if surgery is indeed necessary, really it's quite successful, and they should not be concerned about it.
Well, thank you very much. You have had, what, 5 of your family have gone to U of M, right?
Yeah.
And
Yep.
you taught here for many years with Bob Moyers, and you taught when I was interim chair and when Peter was chair, and so I certainly know that you have a very long association with the University of Michigan, and I'm really glad that next month we'll be able to formalize that with an honorary doctorate from Michigan. I think that's great. So thanks a lot, Tom.
Thank you very much. It's a great honor.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.